Okay.
So, good evening and a warm welcome to all the dignitaries present here. I'm Sreyoshi from Clanet, serving as the allocated session assistant to ensure a seamless experience. Clanet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clanet serves as the digital partner for this event hosted by the Society of Neurocritical Care, and the focus of today's session is optimizing the neurocritical environment, sedation and oxygenation matters. So let's begin today's session, for which I would like to invite Dr. Riyash Javeri sir to take over. Sir is the Director of CCM and Emergency Medicine at Regency Super Speciality Hospital, Lucknow, India. Sir is the Secretary of Society of Neurocritical Care, Dean of the Indian College of Emergency Medicine, and also sir is the Vice President of ISCCM. So welcome sir, and over to you. You can proceed with
Thank
the
you,
talk.
Shesi. Thank you, Shesi. On behalf of Society of Neurocritical Care, I'll welcome one and all. I'll thank the faculty for sparing the valuable time, and also like to thank Clarinet and the delegates for joining us. We have two parts to the webinar today. The first part will be a very lucid talk from Dr. Basil Mata. He'll be talking about optimizing the neurocritical care environment, sedation and oxygenation matters. Dr. Mata needs no introduction to this group, but I'll still do the formality. Dr. Mata is consultant in anesthesia and neurotrauma critical care at Cambridge University Hospitals Trust, and he is Senior Vice President, Global Clinical Affairs and Solutions with Massimo International. And we look forward to a very, very lucid talk from Dr. Basil Mata. Over to you, sir.
Thank you so much. Thank you very much for your kind introduction. It gives me great pleasure to be doing this talk, and I'm sorry it's not being done in person. That would have been even better. Hopefully we'll try and move my slides forward if I can. Come on, you. Oh, what's happening here? Excuse me for a second. I don't know why it's not moving. Okay, let's try that again. Nope. Why? I'm sorry, I don't know why it's not doing what it's supposed to be doing. That's a standard and it's not doing it.
So you can stop share and share once again. Yeah.
Stop share. Okay.
Yes. Yeah, you can try share once.
Okay. Okay, let's try that one. Yeah, it is fantastic. Thank you so much for helping me. So first of all, I'd like to thank you all for being here, all the fellow panelists as well, and Massimo International, obviously, for sponsoring this talk, and all of you for giving up your time. And these are my declarations already been stated. What I really would like to emphasize is that in anesthesia and critical care, the brain seems to be ignored. We monitor everything else. We monitor the heart, the lungs, the kidneys, the liver. We monitor coagulation. But the one organ we seem to forget about is the brain. And it's really surprising because our drugs and techniques work on the brain. Our anesthetic drugs primarily work and affect the brain. It's the most difficult to heal if it's injured, and it can't be replaced. Yet less than 10% of patients who are having anesthesia or critical care sedation have the brain monitored. And if you think about it, this is double what was the case about maybe 3 or 4 years ago. And most of the monitoring for patients who are in neurocritical care or in general ICUs, but the patients with traumatic brain injury or neurologic injury of some sort, in anesthesia, it really focuses on awareness. And we have this impression that as long as hemodynamics is okay, everything's okay. But it really isn't. And it's the job of people in neurocritical care, neuroanesthesia, to highlight the importance of protecting the brain. And it's everyone's job, not just our job in neurocritical care and neuroanesthesia. Now, if you think about anesthesiology, the risk of awareness, what everybody's scared of, is unlikely. It's 1 in 1,000, 1 in 10,000. If you're unlucky, you see it once in your lifetime. And it's almost always because of a mistake. Almost always. A line disconnected, hypotension that you'd reduce the anesthetic for some reason or another. But when you think about all the other things that happen on a daily basis, inadequate anesthesia, of course, is serious in terms of awareness and PTSD and legal issues. But when you look at anesthesia overdose, which happens every day almost, how many of us see patients that are slow to wake up? How many patients are delirious? How many patients have got increased length of stay longer on ventilators, have acute kidney injury because of vasopressors we use, have hemodynamic instability? So the anesthesia overdose carries a lot more damage than the risk of awareness, but yet we seem to ignore that. We seem to accept the fact that overdosing patients is okay as long as they're not aware. And if you look at simple stuff like delirium, for example, there's plenty of studies out there showing that delirium is worse when you have deeper anesthesia if you have burst suppression. Some studies are equivocal, but there are no studies out there that shows deeper anesthesia is better for you than lighter anesthesia or the correct amount of anesthesia. And if you look here at the amount of suppression time on EEG, as you can see in the left-hand column here with red, as the suppression time increases, even 7 minutes, 10 minutes, you begin to see the risk of delirium, how it exponentially rises. And it's again, it's correlating to the level of sedation you have. And the same thing for children, emergence delirium, which people think, oh, it's just a child being angry. Actually, look at this paper here showing the post-anesthesia emergence delirium in children directly correlated to the dose of sevoflurane used. The deeper they are, the more delirium they tend to get. Now, there are some studies who, like this one from the Canadian group, looking an Engage study, looking at the use of process-guided EEG in anesthesia to prevent delirium. And they concluded that this finding does not support the use of EEG-guided anesthesia for this indication. But I just want you to look a little bit deeper at their results. What they found was that patients with delirium had significantly more time with the EEG suppression. They found that the odds of postoperative delirium increased by 4% for every additional 5 minutes of EEG suppression. So really what they're saying here is that if you just don't do anything about the suppression, it's not useful. But how can you tell if there's suppression if you don't manage to monitor the EEG? So to me, it's a self-explanatory situation. If you want to see suppression, you have to monitor the brains. You would never expect, a cardiologist to give anti-epileptic drugs or antihypertensive drugs and not measure the effect on the patient's blood pressure or the effect on the patient's ECG or the effect on the patient's renal output. So why do we give drugs that work on the brain and not measure the effect of what they're doing to that brain? This is probably a more important trial by Kate Leslie and Timothy Short, where they looked at lighter versus deeper anesthesia and the effect it has at 5 days postoperatively, 30 days in 1 year. Now, I don't know how diligent you guys are in terms of seeing your patients after anesthesia. For me, I might see them the day after, maybe 2 or 3 days after if they're really sick. This study shows that lighter anesthesia induces less postoperative delirium and better cognitive function at 1 year. So everything you do in the operation can affect the patient 1 year later. Very, very powerful stuff. Look at intensive care. This is Mauro Odo's group in Switzerland looking at the effect of deep versus light anesthesia, but we're using processed EEG versus non-processed EEG. And what they found is that those patients who have a PSI lower than 25 compared to the patients who have a PSI greater than 95, which is light anesthesia, had shorter duration of coma, less mechanical ventilation time, less ICU stay, and actually lower rate of delirium. So really all the evidence suggesting to us now is that monitor the brain beyond just looking at awareness is really important. Now, the other thing about monitoring the brain is that we're all obsessed with hemodynamics. There's a big thing about guidelines for hemodynamics by the German Society, by the European Society. But you sometimes forget that anesthesia is a myocardial depressant. It's an arteriodilator, it's a venodilator. So when you induce anesthesia and overdose the patient, you create hemodynamic instability. And as Vincent Bonhoeffer's group shown, during conventional anesthesia, most anesthesiologists tend to overdose the patients because they think it gives you more stability and prevent the risk of awareness. But in fact, what they're doing is they're reducing the sympathetic tone, decreasing venous return, causing vasodilatation, and decreasing the blood pressure. And the result of that is that you use more vasopressors and more association with acute kidney injury. So it's very heartening to see that the guideline on cardiovascular assessment and management of patients undergoing non-cardiac surgery now recommend the depth of sedation as part of the overall intraoperative monitoring of cardiovascular systems. Here's an example of what happens when you use pulse guided EEG versus non-pulse guided EEG. This is a randomized controlled trial that was done by Bernd Sogel and Kristen Thompson in Hamburg. What they've done is randomize the patient to two groups of anesthetics. One using pulse guided EEG, one non-pulse guided EEG to maintain the map above 65 millimeters of mercury during vascular surgery. But what they found is that in that group of pulse guided EEG, they used a third less noradrenaline to keep the blood pressure within that side. And so if you infer that AKI has a greater association with the use of vasopressors, this can only be a good thing for patients. When I go talk to people around the world about processed EEG, depth of sedation monitoring, they all say to me, it's amazing how little anesthetic, it's amazing how little sedation you need in these patients once you start looking at the brain function. And it's really, really encouraging to see that after many, many years of lobbying, that the guidelines and intraoperative hemodynamic monitoring and management of adult patients having non-cardiac surgery now include that depth of sedation and optimizing the anesthetic doses is part of that protocol. And also, not only that, but now we're talking about the brain. We're talking about cerebral oximetry as a function of high-risk cerebral hypoperfusion. So really, we have come a long way. And in 2025 now, we are recommending that if you really want to get the hemodynamics right, you need to get the depth of sedation right. So what do we do when we give anesthetics or sedation in the ICU? We really measure what we're giving, not where it's working. So for example, we use MAC, which is not a measure of awareness really, TIVA, predicted value concentrations based on normal subjects, but we don't really measure what the drug is doing at the site of action. We don't measure what the drug's doing at the brain. And we know that hemodynamic parameters alone do not adequately reflect depth of sedation. And again, I think the turning point came for the UK, certainly in Europe in 2021, when the Association of Anaesthetists changed its guidelines to say, hey guys, you need to use pulse-guided EEG, not just for awareness, but also for prevention of delirium, cognitive dysfunction, and improve earlier recovery times. You know, it should be used with TIVA, but not just with neuromuscular blockade. TIVA alone is good, even during inhalation anesthetics, because it reduces the risk of excessive anesthesia, neuromuscular blockade. And also what they said is, come on, you're clever people. Don't just rely on a number. You should be able to interpret the EEG. You should be able to tell the power spectra. You should be able to see the relative power bands. And the American Society of Anesthesiologists followed pretty quickly, although not as quick as we wanted them to do. And they again highlighted the fact that, you know, process-guided EEG and using the DSA can reduce delirium and hypotension, can produce faster emergence, can produce the confirmation of hypnotic delivery, and is suitable for all types of surgery. And they reminded us again that minimum alveolar concentration is a simple population average of the likelihood of movement to surgical stimulus. It is not intended to be a surrogate of consciousness, although most anesthesiologists use it as such. Now, when you come to intensive care and talk to my colleagues, they say, we don't need to monitor the brain because I do the clinical assessment. I use a Richmond agitation and sedation scale. So I keep them at -1, -2. And you go, that's fine. But remember, a third of your patients in ICU cannot have a clinical assessment. Why? Because they're in that first 24 part where the lungs are stiff, you have to turn them prone, they have high ICPs, they've got abdominal trauma or chest trauma. So it's not possible to assess them clinically. So what do? You very much overdose them as a matter of fact. And it's very encouraging to see that, again, that after a lot of lobbying, a lot of work, the consensus group, as part of the European Society of Intensive Care Medicine and Neurocritical Care, has shown that it is recommended that sedated patients in the ICU, whether they're paralyzed or non-paralyzed, who cannot be assessed clinically, should have processed EEG monitoring. And we introduced that to our unit about 2 years ago. And I'm glad to say our use of propofol has come down, our use of vasopressors have come down, and our nurses are a little bit more, similar as our fellows, a little bit more aware of the hemodynamics and the physiology rather than just increasing the sedation all the time. Now, when people talk about process-guided EEG and EEG, they are always worried, oh, I don't know how it works, don't know how it... But, you know, there is no difference between an EKG and an EEG. You're not cardiologists, but you can look at the ECG. You're not respiratory physicians, but you can look at a chest x-ray. You're not neurosurgeons. You can interpret a CT scan. So why is it difficult for you to interpret the EEG? Look at that. You can see PD, you can see seizures, you can see alpha dropout, you can see burst suppression. It's not really that difficult. And most people within 25 to 30 minutes begin to get the basic functions of the EEG. But because people complained about, it's too complicated, we created all these indices. You take all that EEG waveform, put it into a funnel, come out with a number. And people like the number 20 to 40, 25 to 50. Numbers are good, but not all numbers are the same. Why? Because look at this study from Norway, a web-based survey that surveyed all the anesthesiologists and all the anesthetic nurses in Norway. And they got a pretty good reply. They got about 10% of people replied. And what they found was that nearly all the ORs had brain function monitoring in them, but only 10% of people could interpret the raw EEG. 9% could use a spectrogram. 10% recognize suppression. Can you imagine if only 10% of anesthetists recognize, cardiac arrest? 50% considered clinical observation more reliable than their monitor. And 90% of them said they would increase the anesthetic dose if the BIS value was high, but only half would lower it if the BIS was low. So really, just because you have a monitor in the room doesn't mean you're using it the way you should do. And that's why Marson was created, the Patient State Index, the PSI. It's not just a number. It's a number based on the waveforms, but also EMG filtering, low power analysis, artifacts filtering, observer arousal. All of those things are put into it. So it's much more reliable than anything else. But nevertheless, it's still a number. It's very good for trending, very good for looking at, steady in-flight numbers. But, you need to be able to look at more than just a number. So when you go to sleep, the awake state, it's like breathing, fast rate, slow amplitude. And as you get deeper and deeper, the amplitude gets bigger and the frequency slows until you get to burst suppression, where there's periods of activity and no activity, and then isoelectric EEG, where really the brain is sleeping, basically. There's no communication between the cells. And then when you take all those waveforms, take the power, take the frequency, and transform it through a mathematical transformation, you get what's called the DSA. And this DSA here is transforming the waveforms into power, frequency, and time. So the time is running on the x-axis, the frequency is running on the y-axis, and the power is depicted by the color. Red is high power, low power is blue. And you can see here the two white lines, what's called the spectral edge frequency. That is the frequency below which 95% of the power exists. And you can see normally that those two lines are together, they separate and they come back again. Now, one thing unique about the DSA is that, in the SedLine monitor, we use it as a brain health monitor. We use both sides of the brain, not just one side of the brain, because not all brains behave the same. Not all right and left brains behave the same. People with cardiac disease, people with carotid stenosis, people with trauma on one side behave differently. And that's why we have really a 4-channel bilateral EEG. Every drug has got a signature: propofol, sevoflurane, dexmedetomidine, ketamine. And as you get older, the power in your brain reduces. You can see a 35-year-old brain, lots of red in it. Look at a 75-year-old brain, low power in it. And that's where we tend to overdose patients. Patients over the age of 65 and 75 get overdosed because people can't believe how little anesthetic they require. And that's what we've worked on with the SedLine, to analyze those low power brains at those extremes of ages. People will say to you, I don't need to use process-guided EEG because, even on my elderly patients, I use a small amount of volatiles. I don't need to do that. But here's a study looking at 38,000 patients undergoing general anesthesia between 2016 and 2018. And they looked at the incidence of burst suppression based on the amount of volatile anesthetic you use and the age. And look at this. It doesn't matter whether it's induction or maintenance. As you get older, your incidence of burst suppression increases. There's more burst suppression in elderly patients. And look at the last point there. Volatile anesthetics can induce burst suppression at much lower concentrations with increasing age. So when you think you're comfortable, you may well be producing burst suppression in those patients and damaging their brains. Here's another example of why one size does not fit all. You can't go on age, you can't go on weight. These are two children, similar age, similar weight, sex, undergoing scoliosis surgery. One's got neurodevelopmental delay and one has got normal brain. And you can see the child with neurodevelopmental delay is requiring almost half the dose of anesthetic that the child with normal brain is. So if you went on anything else other than processed EEG, you will get it wrong. So what we give you with the comprehensive brain health monitor, not depth of sedation monitor, is the bilateral EEG, the PSI trended, and the DSA. And what I really want to highlight to you is that those black lines with blue tips, that's when you see burst suppression. So when you see a black line or blue tip on it, you need to say to yourself, this brain is unhappy. Why is this brain going into burst suppression? Just like you would see an arrhythmia on an ECG. When you see an arrhythmia on an ECG, you go, why is this heart not happy? You look for a reason. It may be depth of sedation, but it may be other things. It may be hypotension. It may be hypoxia. It may be hyperventilation. It may be turning the head to the side too much. So what you're getting now is really a comprehensive window on that brain. And here's an example of why it's not always depth of sedation that causes burst suppression. This is a traumatic injured patient that came into our ICU, has a PO2 probe inside the head. When the PO2 drops below 14, look at the left-hand slide, burst suppression everywhere. I drive the PO2 above 22 and the burst suppression disappears. This is hypoxia in the brain causing burst suppression. The same thing on this child, undergoing pacing wire. When the asystole happens, the brain stops working, goes into suppression. Circulation starts again, the burst suppression disappears. So that is really important. You know, the EEG is a very, very sensitive measure of how well the brain is doing. Another thing that we can detect with continuous monitoring, the incidence of non-convulsive seizures in neuro ICU approaches 25%. In the general ICU, it's around 10%. Sepsis, trauma, ARDS, all of those things can cause seizures. You can see here on the left-hand slide, normal sedation. In the middle, you begin to see the spikes appearing, and then on the right-hand side, you see the full-blown seizures. And what we do is we monitor our patients, all of them, and when we see spikes, we start them on antiepileptics, and then we get a full montage EEG. Some people say to me, yeah, it's difficult sometimes to put the monitors on. There's plenty of publications now showing you that you can put those EEG stickers in a variety of places and seriously get a good signal and a good interpretation of what's going on inside that brain. And last but not least, you all believe in sustainability. We want to live forever. We want to go to net zero. People are trying to get us to plant trees. People are trying to get us to use total intravenous anesthesia, less syringes, less pipes. How about getting the right dose of sedatives and the right dose of anesthetic, and then we don't have to destroy the planet. We don't have to have people ventilated for longer than they need to. We don't have to use more drugs than we need to, and we may improve the outcome. I spoke about depth of sedation. I want to spend the next few minutes talking about oxygenation. Now, the brain is very, very sensitive to changes in the metabolism and oxygen delivery. So anything that imbalances the oxygen delivery to the metabolic requirements of the brain will cause a brain injury. Whether it's perfusion, whether it's vasospasm, whether it's low blood pressure, whether it's anemia, or whether it's an increased metabolism, for example, pyrexia, seizures, stimulation. And the brain is clever in that it has something called flow metabolism coupling. When the blood flow goes up, it's generally because the metabolism has gone up. When the metabolism comes down, the blood flow comes down with it. When you have an imbalance between blood flow and metabolism, you get too much blood flow, you get hyperemia. Too little blood flow, you get ischemia. And we want to keep it in the middle as much as possible if we can. Now, NIRS, cerebral oximetry, works on the principle that we really measure the balance between what we're delivering, what we're consuming. So pulse oximetry looks at the amount of oxygen being delivered because it shines a light from one side to the other and looks at the oxygen saturation in the arterial blood. A cerebral oximetry, we don't do that. What we do is we measure the amount of oxygen in the tissues based on the balance between what's being delivered and what's being consumed. So we look at the balance between oxygen delivery and oxygen consumption. Delivery is dependent on the cerebral blood flow, mean arterial pressure, cardiac output, CO2, and consumption is dependent obviously on brain activity, depth of sedation, seizures, etc., etc. And so how do you look at cerebral oximetry? Well, there's several ways of doing that. You can put a jugular bulb catheter in, which sits around a C1 level, a reverse IJ. You can put a PO2 probe, which is what we do in neurocritical care here, or you can use NIRS. But in reality, you know, unless you are having neurosurgery, unless you're in a high critical care unit, you're not going to be using PO2 probes. You're not going to be using jugular bulb catheters. You're not going to do that in liver transplant. You're not going to do that in shoulder surgery. So you really are left with NIRS. And the way it works is it's different to pulse oximetry, and this is reflectance spectroscopy, not transmission. So basically what we do is we shine lights through the skin, scatter it around the brain, and pick it up with detectors. So one shallow, one deep, and we subtract these two things from each other, and we calculate the saturation underneath that probe, roughly 70% venous, 30% arterial. So if we go back to the flow metabolism coupling, when the flow metabolism is coupled, the blood flow goes up, metabolism goes up, there's no change in saturation. When they both come down in the same direction, there's no change in saturation. When there's an increase in saturation beyond metabolism, the saturation will increase. When there's a decrease in blood flow more than the metabolism, then we'll get a reduction in saturation. So you can see how it tells you, RSO2 tells you that balance between what you're delivering, what you're consuming, but it doesn't tell you why it's happening. What's the normal value? It's very difficult to get normal value from comparative. So you look at volunteer studies. This is an example, 32,000 observation, 98 volunteers, different ages, different color skin, indexes, map, age, height, weight. And we all agree that once you get below 55%, really you are getting towards the lower limit of comfort. Most people expect 55 to 80% to be the normal range. And that's where we're all working at. How accurate is it? If you look at the Massimo cerebral oximeter, we have an absolute accuracy of 2% and a trend accuracy of 4%. And again, trend accuracy is much more important. It doesn't matter whether your saturation is 66 or 64. What matters is if your saturation is 66, going to 64, going to 62. So the trend value is much more important. Now, the trouble with RSO2 or brain saturation is it doesn't tell you why it's changing. So that's why we've introduced 3 new parameters on that cerebral oximeter for you. The changes in total hemoglobin, oxygenated hemoglobin, and deoxygenated hemoglobin. So now the 3 components that make up that cerebral saturation can be observed at the same time of the saturation. So what does that mean? Well, you know the balance of the saturation is oxygen delivery divided by in balance to oxygen metabolism. Now, because you have the component of oxygen delivery, which is the change in oxygenated hemoglobin, and you have the component of metabolism, which is the change in deoxygenated hemoglobin, you have the full picture. You have the RSO2, and you have the components that tell you about the consumption, and the component that tells you about delivery. So you get a measure of the saturation under the optodes. You get a reflection of the total blood volume under the optodes. You get a reflection of the venous component. Sometimes you get the saturation drop because there's venous obstruction, because there's venous congestion, not because there's increased consumption. And the last thing you get is the change in oxygenated hemoglobin, which you can look at for hyperemia, vasodilatation. So the clinician now is able to see the saturation and can tell why it's changing. Is it dropping because I'm delivering less, or is it dropping because the consumption is increased? And there's different treatments based on what you see. Now, we use bilateral cerebral oximetry because this is an example of a patient undergoing aortic aneurysm root repair. They put a stent in. Everybody was happy at the end of the procedure, except the anesthesiologist who said, hold on a minute, guys. One side is 49, the other side is 74. The stent has gone up a little bit and obstructed the left carotid. They pull it back and everything is okay. Here's a patient from our unit, traumatic brain injury, aortic dissection. They put a stent in, sacrificed left subclavian, left carotid was filling, not brilliantly. Come back to the intensive care unit. Difference is 58 versus 79. 3 choices. Take them back to the angio and fix it. No, too difficult. Wake them up and hope there's enough reserve, or keep them asleep until the collateral circulation develops, which is what we did, and everything was okay 3 days later. It's not just in neurosurgery, cerebral oximetry is important. In the UK, there's been a few reports of stroke in young, fit, healthy patients undergoing shoulder surgery in the beach chair position. So a lot of the hospitals now recommend cerebral oximetry as an indicator of adequacy of brain perfusion. On the left-hand side here, you see a patient with the head down position having robotic surgery and insufflation of gas into the abdomen. What happens there is not the saturation drops, not because of the reduction in delivery, but because there's venous congestion. So these patients wake up with swollen eyes, swollen tongue, swollen ears, like superior vena cava syndrome. And again, it's been very useful. One of my colleagues in Italy is now looking at the optic nerve sheath diameter, and she's showing that, you know, as you keep them head down, their brain cerebral edema increases. And this is an example of what we do. We do what's called, venous decongestion. This is a patient, as you can see by the 2 arrows, has got a narrowing of the venous drainage. I put a cerebral oximeter on them, and as they put the stent in and dilated that vessel, you can see how the saturation increased. The saturation increased not because there's an increased oxygen delivery. It increased because the venous congestion has been removed. And these patients feel a lot better afterwards because they normally feel like they have a washing machine in their head. And this is what happens. And last but not least, patients are undergoing non-cardiac surgery, for example, or non-neurosurgery. This is an example, a patient undergoing transaortic valve replacement, looking at cerebral oximetry in them. And what they've shown is that really this starting baseline cerebral saturations correlate very well with cardiac function. They correlate with BNP, left ventricular diastolic pressure, systolic pressure. All of those things correlate with the saturation, because when your brain is not getting enough blood, it means the heart is working very hard, but not delivering what it needs to. And those patients who start with lower saturations tend to have the longest period of prolonged hypotension once the valve has been released. And every country, every unit has got this protocol. This is our protocol in Cambridge we use for cerebral oximetry. Now, I want to combine both cerebral oximetry and really depth of sedation. So you can see here that on the same monitor, you can have depth of sedation and cerebral oximetry. On the left-hand side, patient's gone into burst suppression because too deep an anesthetic, and the brain saturation is dropped because of the drop in blood pressure. On the right-hand side here, the patient goes on to bypass. They're desaturating the brain. Then you can see that they go into burst suppression. So the two things would look the same if you used one monitor only. But to get that information is you have to have both monitors. So on the left-hand side, you lighten the anesthesia. On the right-hand side, you increase the flow on the pump, on the bypass pump. So different treatments for different patients. Here's an example of a patient that came to us about 3 months ago. A young 23-year-old, no injury except for bilateral femoral fractures. He went to the operating theater, had both femoral fractures fixed, and came back with an arterial saturation of 82%, GCS3, and his X-ray looks like he's got fat embolism everywhere. So the choice for me was go on to ECMO or see what's happening with his brain. I put brain oximetry on him. I put depth of sedation monitor on him, and his saturation was running around 55. He wasn't deeply sedated. I deepened his sedation. The saturation came up to about 59, 60. I let the CO2 creep up a little bit more. Saturation went up above 64, 63. I waited 2 days, sitting on him with arterial saturations around 84, 85. As long as his brain was being protected, you can see here his fat embolism disappeared, and we finally extubated him. Again, I wouldn't be able to sit on a patient with fat embolism with arterial saturation of 83, 84 if I didn't monitor their brains to make sure they are okay. Now, I want to finish off by talking about pressure autoregulation. We know what cerebral autoregulation is the ability of the brain to maintain constant blood flow in the face of changing perfusion pressure. It's difficult to measure. We need to use transcranial Doppler. We use PRX when you have an ICP bolt in. But it's becoming more and more important, not just in traumatic brain injury, in sepsis, post-cardiac arrest, in eclampsia, in general trauma. So we're beginning to realize that actually the way to protect the brain is keep those patients in the autoregulatory range. And we in Cambridge use ICM+, so we monitor the ICP continuously, we monitor the blood pressure continuously, monitor the perfusion pressure, and we do a correlation between the changes in ICP, which is the volume reflected and the changes in basically the blood pressure. And we plot them together, and when you have good autoregulation, when the blood pressure goes up, the ICP effectively comes down. When the blood pressure drops down, the ICP goes up. And we plot that, and you can see here on the bottom scale, the PRX, when it's below 0.3, we think they're autoregulating. And we made it easy. Red means no autoregulation, and green means autoregulation. And why is it important? Because this is an example of the using cerebral oximetry for assessing autoregulation in patients undergoing vascular surgery. You can see that the patients who stay within the autoregulated range have less incidence of delirium, whether they're in the ICU or whether they are in the operating theater. So autoregulation's got some form of ability to protect the brain in hypoperfusion and hyperperfusion. Same thing about cardiac arrest. What is the right blood pressure for cardiac arrest? You know, some people require a map of 109. Some people require a map of 75. Again, a lot of the trials now are going towards optimizing post-cardiac arrest blood flow by looking at cerebral autoregulation and keeping them within that range. And last but not least, mechanical thrombectomy. If you look at mechanical thrombectomy there, you know, these guys looked at the ability of keeping outcome related to the blood pressure you keep. And what they found actually, that it's exceeding the limits of autoregulation, not the fixed blood pressure thresholds that are associated with poor functional outcomes. So again, autoregulation limits are becoming more and more important rather than just looking at blood pressure alone. And what we have done here is we've taken the Massimo O3 signal, put it through our ICM+, and it works pretty well, almost like the PRX. So I'm going to show you that, for example, what we During Cambridge, we use what's called CPP optimal. We calculate autoregulation over a period of time, and we decide what is the best autoregulation at which blood pressure, and then we aim for that patient to have that blood pressure. And here you can see the lowest limit, the lowest PRX is supposed to be the best autoregulation. So we try and keep the blood pressure of that patient around that thing. But it's difficult to do. You have to put an ICP bolt in, you have to put a transcranial Doppler. So we've done it with cerebral oximetry. And here's a study that Peter Smilaski and his team did, looking at the ability of cerebral oximetry to assess autoregulation using the cerebral oximeter. And what we found was that actually cerebral saturations are okay for looking at autoregulation, but they're not as good as looking at the slow wave being transmitted. And so what we're doing is we're looking at the O2 HBR, which is the arterial component, as well as the venous component, to give you a complete picture of autoregulation using the cerebral oximeter. And here's an example. What we have is the MX, which is used transcranial Doppler to assess autoregulation, the PRX, which uses the volume changes, and you can see here the autoregulation index measured through cerebral oximetry, right and left, using our oximeter. And we are in the process of completing this work now. You can see that we are pretty reflective what happens with the highly invasive methods, and that will soon be available in the cerebral oximeter from Massimo. I want to really finish off now by talking about what is the point of all our circulation is really to deliver oxygen, remove waste products. We've talked about depth of sedation, we talked about oxygenation, but really ultimately we need to have good blood pressure, good flow, and good circulating volume. The trouble with blood pressure is that, hypotension, of course, is associated with poor outcome, but not all hypotension produces poor outcome. For example, we have got hypotension that doesn't produce an increase in stroke. We've got hypertension that doesn't improve outcome. We have a study showing that maybe hypotension is better than hypertension. So blood pressure alone is not the answer. If you move a little bit further, you can see that hemodynamic monitoring gets us a little bit better and closer to oxygen delivery than just, for example, blood pressure. Here's an example of reduction in post-op complications using hemodynamic monitoring as part of the management, whether you look at mortality, whether you look at length of stay, whether you look at reduction in cost. This is all the way it's going in terms of we need to look at more than just blood pressure to improve outcome. And when you look at oxygen delivery, for example, this is a study looking randomization of oxygen delivery above 280 mils per minute per meter square versus normal care in patients undergoing cardiac surgery. And you can see that the incidence of acute kidney injury is so much higher in the patients that do not maintain the DO2 above 280 mils per minute per meter square. And the same thing from this study from Richard Newland in Australia, who showed that once you go below 270 mils per minute per meter square, the incidence of AKI is 3 times as high as normal patients. So oxygen delivery is where it's at. So we know blood pressure is needed to have flow. We know adequate flow is needed for perfusion, but blood pressure does not mean adequate flow, and flow does not mean adequate oxygen delivery. So in order to measure oxygen delivery, you need the cardiac output and you need the oxygen content. The trouble with measuring the cardiac output and the oxygen content is you have to really have a PA catheter, you have to take blood samples, and it's a one point in time. So you really need continuous hemoglobin. You really need to have a continuous cardiac output. And this is the importance of hemoglobin that I sometimes point to people. People tend to forget that persons with cardiac output with different hemoglobin have different oxygen delivery abilities. So really we have to keep that in mind. And that's why we run most of our patients in neurocritical care around the 9 to 10 grams of hemoglobin as opposed to 7 to 8. And with the Massimo Rainbow technology, we can measure continuous hemoglobin. And so you can see here the trend in hemoglobin versus lab values. It really is a pulse oximeter with the ability to measure hemoglobin. You can see it can tell you when the hemoglobin is dropping. It can tell you when it's rising. It can tell you when it's steady. So it's a very good trend of hemodynamic monitoring when it comes to hemoglobin. And that's why when you use it as part of your orthopedics, general surgery, neurosurgery, there's a reduction in number of patients transfused, fewer units, quicker transfusion, cost reduction, but most importantly, a reduction in 30 and 90-day mortality, which is really why it's found its way into almost every blood management protocol there is now. SABAM, NATA, European Society, the American Society, all of those are recommended as part of your management strategy. But really, that only gives us one element of the oxygen delivery. So what we've done is we've taken that LIDCO machine, the big cumbersome machine, and created a little device that plugs into any arterial line. And as long as you plug it into any arterial line or any monitor and plug in your hemoglobin sensor, what you get is not just cardiac output using the power and the pulse pressure, but also because of the hemoglobin, you get oxygen delivery. So what you get is beat by beat oxygen delivery through the decision tree. You can see what exactly happening when you increase the blood pressure, when you give more hemoglobin, when you give more fluid. You can tell all that on one screen. And I think this is a bit closer than just looking at blood pressure or cardiac output alone. So you really are looking at the patient, looking at what's happening with that oxygen delivery. And when you couple that with what I've just talked about in terms of metabolism with SedLine, regional oximetry, looking at tissue oxygenation, you really have a total platform, totally minimally invasive platform, starting with pulse oximetry and hemoglobin, going all the way to hemodynamic monitoring, and eventually looking at the vital organs, which is most important of which is the brain, using SedLine and O3. So I want to stop now and thank you all for listening to me. And I'm sorry if I was too fast, but I think it's important to highlight all these things to you.
Thank you, Dr. Basil. It was a very, very elaborate talk, and we all loved to hear you. We could understand the intricacies of neuromonitoring. We'll go on to the question and answer sessions. There is a question from Dr. Subhash Balhara. He's at Denmark. Role of PA catheters in neuro ICU.
You're asking me the role of PA catheters. So before the bad publication that showed PA catheters are bad for you, we were the highest users of PA catheters in the world. Okay. I used to put in a PA catheter 2 or 3 times a day in most patients. Okay. And we stopped all of a sudden. And I think there is a role to play for PA catheters in the ICU. Because really, to be honest with you, the alternative is nothing at all. The alternative is we just look at the blood pressure, and what do we do all the time? Unless your unit is different to many of the units I visit, what we tend to do is give more fluids and give vasopressors. But we have no idea what the heart is doing. We have no idea what the PA pressures are. So I really think in the sick patients, we need to go back to not just looking at blood pressure, but looking at something more than blood pressure, maybe fluid responsiveness, maybe contractility, maybe oxygen delivery. But we need to move away from just looking at blood pressure alone, because I don't think that is the answer.
Yeah. Dr. Subhash Balhara, you can.
Very nice presentation, Dr. Basil. I just want to ask, because thing is, I am working in neuro-intensive care in Denmark, and we don't have any we don't even use PA catheters in our new ICU. That is only used in cardiac ICUs. And thing is, I don't think advantage over PICO catheters in relation to this one, but we monitor continuous ICP, continuous CPP, continuous other PTI O2 also that is also available in our ICU. How do you see the difference between PTI-O2 monitoring versus your oxygen?
Okay, so unless your unit is wildly different to every other unit around the world, what happens for us is a patient gets injured in Norfolk. They ring us up and say, this patient's got a traumatic brain injury. We say, ship them over, okay? So the call goes to neurosurgeons. The neurosurgeons call the transfer team. The transfer team, luckily we have an adult critical care transfer team, so it goes and gets the patient. With the best will in the world, that takes 3 or 4 hours. So you get the patient 3 or 4 hours later. Then they arrive and the surgeon will say, the injury is not too bad. Try and wake them up. We try and wake them up. They don't wake up. We put them back to sleep. Let's scan them again. We scan them again. Yeah, okay. Let's put an ICP bolt in them. We've lost 8 to 10 hours on average, if we're lucky. Okay. And what we started doing is putting cerebral oximeters on these patients and depth of sedation monitors before they leave their referring hospital. So at least we have a measure of oxygenation until they get to us. Now, if you have severe traumatic brain injury, we put a triple bolt in you. There's no question of that. But what about the mild head injury? What about the subarachnoid hemorrhage? What about the patient who's come in with pelvic fracture, long bone fractures, and very minor trauma? What about the patient going into main theaters to have their pelvic fixed when they've had a small, tiny contusion? Those patients don't get ICP bolts. So what we're trying to find is non-invasive technology is helping us decide. Many of our patients now have cerebral oximeters on them and depth of sedation on them to get at least the global hemodynamics picture right, rather than worry about the particular detail of that. Of course, it won't prevent regional ischemia, but it prevents global ischemia.
What about what type of sedation you are using in your ICUs?
Well, we use primarily propofol and fentanyl, but to be honest with you, sometimes we resort to using ketamine, dexmedetomidine, and midazolam.
Dexmedetomidine in TBI?
Dexmedetomidine in everybody.
Okay, you use it, because we don't use it up to 21 days after TBI.
Well, the dexmedetomidine is the data is equivocal. Some people say it's better for delirium, some people say it's not. But when we're running on, say, 15 mils of propofol, running on 10 mils of fentanyl, you're already running on high dose ketamine, you paralyze the patient, you're still struggling. People tend to add other stuff, and dexmedetomidine seems to be a good one for reducing, as we begin to wean them.
I'm not contradicting you, but why don't you use midazolam and fentanyl?
Because midazolam has been shown to have the highest incidence of delirium after that. We use midazolam, but I don't see the benefit in having 25 mils of midazolam running an hour. Once you go beyond 2 or 3 mils of midazolam, the effect on brain metabolism is minimal. It really is minimal. And
What are you afraid
one
of?
the
Like
problems,
rising ICP?
sorry?
What are you afraid of? Like rising ICP or what?
Yes,
Like
yes. In fact, actually, one of the main problems we have when people switch from propofol to midazolam is that you begin to see rises in ICP. So sometimes we get propofol infusion syndrome symptoms. People worry about it, and we switch them because midazolam is not a good suppressor of brain metabolism. It's very good for disrupting the connections and giving you, amnesia, but it's not a very good reduction of brain metabolism. Same as fentanyl. It's not a very when added to propofol, yes, it works, but as a sole drug, it's not very good at reducing brain metabolism.
thank you.
Thank you. Any other questions? Okay, Dr. Basil, what would be a good choice of agent for paroxysmal sympathetic hyperactivity, especially in young traumatic brain injury? And what will be the good neuromonitoring tool for the same patient, paroxysmal sympathetic hyperactivity?
We use beta blockers, to be honest with you. If we think
Yeah.
there is excessive parasympathetic activity, we use beta blockers. But obviously, there's always a risk of drop of the blood pressure. But generally speaking, those patients are tachycardic. You bring down the heart rate to a reasonable level. We wouldn't start someone on that if they're running a heart rate of 70 or 80. But if they're running a 120, 130, then we would add a beta blocker.
Okay, so if there are no more questions, we'll move on to the next part and probably we can continue with the same discussion. Next part of the program, we have a panel discussion. How minimally invasive monitoring and vital organ monitoring platform can help optimize sedation and ensure oxygenation. And to moderate this session, we have no other than Dr. Harsh Sapra. Dr. Harsh Sapra needs no introduction to a neurocritical care group. In fact, he was the first president, and Society of Neurocritical Care is his brainchild, and he has worked very hard to make it what it is today. Dr. Harsh Sapra is Vice Chairman, Neuroanesthesia and Neurocritical Care at Vedanta Super Specialty Hospital, Gurgaon. We have a very esteemed group of faculty or as panelists. We have Dr. Basil Mehta, welcome you again. We have Dr. Srinivas Samvedan, a very dear friend, a very aggressive intensivist, and he loves his work. And he has been the president of Indian Society of Critical Care Medicine, keen researcher, keen clinician, and a very helpful friend. We have Dr. Shalini Nair. Dr. Shalini Nair is from CMC Vellore. She is professor of neuroanesthesia and critical care. She is the dean for College of Neurocritical Care. We have Dr. Subhash Balhara. Welcome, Dr. Subhash.
Thank you.
He is practicing anesthesia and critical care at Denmark. He has been the country representative for ESICM from Denmark. He did his graduation from PGIMS Rohtak. Welcome, Dr. Subhash. We also have Dr. Prashant Kumar. Dr. Prashant Kumar is president of Society of Neurocritical Care. He is my college senior and he is professor of anesthesiology and critical care at PGIMS Rohtak. We also have Dr. Subhal Dixit. Dr. Subhal Dixit is past president of Indian Society of Critical Care Medicine. He has been holding senior posts at various societies. Presently, he is the president of Indian Society of Parental and Enteral Nutrition. Over to you, Dr. Sapra, sir.
Thank you, everyone. Thank you for joining the panel. Such a esteemed panel, and Dr. Mata has made our work simpler with such a lucid discussion. So, so if I may start my panel discussion, moving on from the same page. I remember learning from you, Dr. Mata, in 2018 when I visited Cambridge for a week. You had a good session in which you taught me, and then I went to Peter Slovensky for the ICP net and the good discussion regarding the same parameters then as well. So taking a leaf out of today's discussion, I would welcome all the panelists, and if you may all allow, I will start the panel discussion, and I will address the first question to Dr. Prashant. As to Dr. Prashant, how do you define the threshold at which vital organ monitoring should shift from conventional to advanced in sedated patients?
Good evening, all. Thank you, Dr. Harsh, for giving me the first ball for the panel. And I think Dr. Mata has already uh, told everything about and brought us to a platform where we need to understand about our thresholds. And when we look at the thresholds, we start looking at now what would be the balance in terms of if I look separately, the threshold for oxygenation, it would be different. If I look thresholds for my sedation, my parameters would be different. But when I club them together, I'll be balancing between thresholds which would be much lesser for sedation and much important for oxygenation. And both the balances would shift in different directions to bring it to a level where we have a balance where my sedation does not cause hemodynamic instability at the tissue level, not at the central level and looking monitoring at the central compartment and arterial blood pressures only. What is required is what is happening at the tissue level, which causes the ultimate tissue damage to the brain as well as other important organs. So that balance is my talk.
Yeah, so you now decide to move away from MAC to neuromonitoring per se.
I fully agree with it.
Yeah, and if I may ask you, in what subset of patients, in all your patients, or in a particular subset of patients?
Now, I'll start with my personal experience, which started changing my practice in terms when I moved from general anesthesia to neuroanesthesia and then neurocritical care. So, what happened a couple of months in neuroanesthesia, and I started realizing someone asked me a question, what is the difference in your general anesthesia practice and neuroanesthesia practice? And I used only one line that I have a very thin line, very thin margin of maintaining hemodynamics in my neuro theaters, which I have much more in my general operation theaters. Saying that, it brings to me the level, what I'm talking about is the auto-regulation. The auto-regulation for my general anesthesia or general theater patients or general ICU patients has a much larger range. But when it comes to my neuro patients, be it in theater, be it in ICU, my ranges, they become very thin. And that is what brings the change between a general ICU and a specifically neuro ICU. Now, coming to a specific question, what you asked me, given a choice, I want all my patients to have the balance of uh, this thin line, and all the patients should have a very narrow therapeutic range to be kept for the hemodynamic sensation, not only in neuro, but yes, specifically my neuro patients, they are different and they need very specific.
Sure.
If I may add just one thing here, I think
Please,
what you
please.
highlighted is really important. But what I really been driving is try and move us, the way the American Heart Association, for example, legislates on how you should do with stroke patients outside, they're not stroke physicians, but they tell us what to do. The same thing, the cardiac societies tell us how to manage patients with cardiac disease when they're going non-cardiac surgery. And what I'm saying is that our role as neurointensivists, neuroanesthetists, is to tell people who are operating on patients how to protect those fragile brains when they're not having neurosurgery or neurointensive care. For example, if you have an elderly patient having a revision hip when they're in trouble. And all these things are really important. So I would like us to be able to say to people, no, you can't hyperventilate a 70-year-old down to a CO2 of 4 because you don't know what's happening in their brain. No, you can't drop the blood pressure because you think it's okay, because you don't know how vulnerable that brain is. And I think we need to be moving the conversation to say, the brain needs to be protected, not just in neuro, because we already are protecting that, but outside neuro, because the 40-year-old with chest trauma and abdominal trauma needs more of their brain protected because it's not injured yet. And we allow it to get injured because we sedate them too deeply or we drop the hemodynamics too much on the assumption that, it doesn't matter. But it really does matter, because those patients are the ones that have not come in with a brain injury. And then we want them to leave without one. And that's where I think we should be all really involved in guidelines, in setting standards to say, no, it's not acceptable for you to sit a patient up having shoulder surgery and keep the mean arterial pressure below 90, because that's not acceptable in that patient, or whatever number you choose. So I think what you're saying is correct, but we need to take that practice from neuro to outside neuro and say, how do you manage patients on general intensive care with paracetamol overdose? What's happening to those patients? Are they seizing? Have they got swollen brains? What are you doing to monitor their brains? Because I can guarantee you most general intensive care units will not monitor those brains.
So this is exactly what I was coming to in my next question. What about monitoring the patients, the non-neuro patients? We all monitor the neuro patients, but what about a patient undergoing a surgery which is not neurosurgery, a general surgery? Would you monitor? So I would address this question to Dr. Subhash. Dr. Subhash, would you be covering non-neurosurgical patients as well? You are muted, I think,
Subhash,
Dr.
just unmute yourself, please.
I know. Please. Can you hear me now?
Yes, please.
I'm only working in neurocritical care as well as trauma patients, but we are involved in all the patients, like when they come in the the acute emergency, and I don't like anesthetize them, but still we don't neuro monitor, like we don't put ICP monitoring in those patients, but as Dr. Mata told, like it's important that they should maintain like the parameters, basic parameters, CO2. We don't hyperventilate them. We don't they don't go in hypertension. That's very important for the elderly patients, especially. The
Right.
thing is, we don't know what's happening in their brain.
Sure. So let's move on to the next question. I think Dr. Prashant and Dr. Mata have clubbed it nicely, saying that we need to monitor it not only in the neurosurgical subgroup, but also in the general surgical subgroup where we think advanced monitoring is required. So next, I'd like to bring in Dr. Srinivas. And Dr. Srinivas, I know you are a very keen intensivist and you are very well researched. So, if I may, I ask you, how can EEG based and respiratory drive monitors help us titrate sedation without compromising oxygenation? And what do you do in your practice?
Well, I'll start from the oxygenation perspective. Uh, while we all understand that low oxygen tension in the brain is detrimental to an injured brain, and so in a neurocritical care unit, it is assumed that you monitor the cerebral hemodynamics and the cerebral oxygen dynamics as well. But in a non-neurocritical care patient, for example, an ARDS patient, a septic shock patient, a post-cardiac arrest patient, sometimes in the excitement of managing the basic disease of optimizing the tidal volume, the PEEP, the driving pressure, the mechanical power, or getting the hemodynamics right, we tend to forget what's happening upstream to the circulation, and that's what we are now trying to focus on. uh, Not that once one number is prescribed and we follow that for all patients. So a combination of hemodynamic assessment, systemic hemodynamic assessment, cerebral hemodynamic assessment, cerebral oxygen assessment, coupled with what is happening to the electrical activity of the brain. For all patients on whom you do not have a subjective clinical assessment of the neurological integrity. That is what we are now practicing. And thankfully, over the last couple of years, we have had tools like the brain sonography. You have tools like pupillometry quantitative pupillometric index. We have the NIRS, and of course, we have the CPP and bedside EEG monitoring. The advances in technology have now helped us to minimize the number of disconnections and connections we do for the EEG monitoring. The braces which are available, which connect with Bluetooth and you can monitor it from a distance, will help are helping us to have a comprehensive multimodal monitoring specifically for the typical example. If I may, if I'm given one more minute, I will elaborate on it. Is our patients on ECMO, right? You have patients who have severe hypoxemic respiratory failure who go on ECMO with decent anticoagulation, and you have no method, or you don't have the opportunity of assessing their neurological status for the first 48 hours. Your focus is on something else. But if you can use these tools, you will be able to predict whether what you are achieving in the systemic circulation in terms of oxygenation and ventilation is what you are also translating into the brain. That gives you an assurance that when you are trying to wake up these patients maybe 72 hours after initiation, you are on a sound footing and you have a higher chances of having a neurologically appropriate patient.
Yeah, thank you. Dr. Shalini, I know you look after the neurocritical care unit at CMC Vellore. So, do you integrate, and you have worked with Dr. Mata and Dr. Gupta in Cambridge. So, I would just want to ask you, do you monitor, do you use EEG based monitors in your intensive care unit?
So I'm amazed at what that little monitor that Dr. Mata spoke about gives so much information. Yeah, almost 25% of the traumatic brain injuries not waking up could be attributed to non-convulsive seizures. It's a must. But unfortunately, right now, we do not have continuous EEG. We only have periodic EEGs when we suspect that it could be a subclinical seizure. And we have, even with that, we have detected quite a few. And whenever we have status epilepticus, we do monitor. But I think we are moving towards unarguably continuous monitoring of EEG. It should become must for non-waking up patients.
Right. So my next question I would address to Dr. Shubhal Dikshit, who is a very is the past president of ISCCM and is a very learned intensivist. So, Dr. Dikshit, I would want to ask you, can vital organ monitoring preempt multi-organ dysfunction in sedated, ventilated patients?
Yes, thank you, Dr. Sapra, and thank you, SNCC, for the warm invitation today. Sorry, I have to join on the mobile because of electricity problems. But most importantly, the question what you said is yes, optimizing of the multiple organ failure is very, very important in neurocritical care. One, because as Dr. Srinivas has also said, and all the present speakers have said, yes, you need to have a good balance between optimization of sedation as well as oxygenation. That is also to maintain the hemodynamics. And if you don't maintain the oxygenation, sedation in order to avoid secondary insult to the brain, which can also cause hemodynamic problems, which can also cause alterations in the perfusion of various vital organs, that may also precipitate a further hypoperfused state into different organs of gut ischemia, paralytic ileus, or renal amount of renal blood flow will go down, and that may precipitate certain amount of the various organ dysfunctions. So therefore, a good amount of a balance between sedation as well as oxygenation, as well as to maintaining the hemodynamics of the patient is very important. And for that, definitely the main goal is to avoid and prevent a secondary insult to the already injured brain. For example, in traumatic brain injury, you have to also see that the metabolic demands of the brain are also reduced, and therefore to maintain sedation, oxygenation, and hemodynamics in order to maintain a good perfusion of vital organs is very important to prevent multiple organ failures.
So, Dr. Dikshit, you are very widely practiced and your area domain is very wide. and you are one of the leading intensivists of the country. If I may ask you, would you be doing this neuro monitoring or brain monitoring in your general ICU patients, maybe non neuro related patients, where you think the brain function might be important or it can change outcomes?
Definitely one in certain units where those who have got the access of doing transcranial Dopplers, there we can monitor the cerebral perfusion, they can easily do it. But those patients who are with sepsis, with encephalopathy, if you think that the cerebral hypoperfusion is down, definitely you can monitor one, the cardiac output, that's one. Another thing to see whether there is cerebral edema, the easiest non-invasive way, as what Dr. Srinivas has also said, you can simply do an optic nerve sheath sonography to monitor the thickness of it to see whether there is evidence of any raised intracranial pressures. These are the simple non-invasive things which can easily be done and monitored. That's what in my unit we definitely monitor it in those patients with sepsis. Definitely because of limitations of availability of transcranial Dopplers at a higher end of monitoring of neuroimaging.
Yeah, thank you, sir. Thanks. So, Dr. Shalini, if I may drag you into the next question. So, what do you think is the role of cerebral oximetry or non-invasive cerebral oxygenation in critical care patients in your unit?
I I completely agree that it has to be monitored, and without that, you absolutely have no clue what's happening to the brain, why it's not waking up or it's not functioning as optimally as it should. I remember when I returned from Cambridge, having worked with Dr. Martha and his colleagues, I was all starry-eyed. It had to be ICM plus. But in LMIC, the reality is a little different. The invasiveness keeps these parameters a little at bay. It's very difficult to bring it in so easily. In non-invasive, the way you can monitor NIRS is a one big tool, and it has to be monitored because otherwise you have no idea, especially in polytraumas where you have the lung injured, there are contusions or ARDS or infections with WAP. In any such situation, which is very common in a TBI patient as well, without knowing what's happening to the oxygenation of the brain, you are simply groping in the dark. You have no idea what the outcome of the patient is going to be. I think it has to be done, and it should become almost an essential tool.
Thank you, Dr. Shalini. Dr. Mata, if I might ask you, what subset of your patients would go in the arm of the ICM plus, and how many of percentage of your patients would be monitored with non-invasive tools like the SedLine or
Yeah.
the cerebral oximeters?
So basically, anybody who has an ICP bolt goes into the ICM plus protocol because we calculate the parameters on that. Anybody who's sedated on the ICU has a SedLine monitor on, and anyone who we think has a reason to worry about oxygenation has a cerebral oximeter on. Generally speaking, when I'm on, all the patients have them on. When some of my colleagues are on, it can miss. But I say to all the fellows, and your guys will tell you that you're here to learn what not to do, not what to do. You learn everything, and then you decide what you don't want to do, because everyone can tell you what to do, but in reality, you have to be convinced of what works. And to me, I really, I don't see how you. I mean, optic sheath diameter is excellent, but you have to do it intermittently. Transcranial Doppler, very difficult to keep on continuously, So really the beauty of EEG, and I know people think frontal EEG, really there are no significant non-clinical seizures that you don't see in the frontal EEG. People talk about cerebral oximetry again being in the frontal lobes, but we're not monitoring the frontal lobes. We're monitoring the most vulnerable area in that brain, the ACA, MCA, watershed area. So we were talking about global hypoperfusion. You will see it there. That's the area you will see it in. So to me, it's a straightforward thing. If it was my brain, I'd like it monitored.
Yeah. So on the same page, what do you think? How many channel EEG would be enough for monitoring in neurocritical care unit? 4, 8?
Well, for us,
For intensivists, not for a neurologist, but for an
for
intensivist.
us, We have four channel. And we see the majority of things. We're doing some work on seizure detection because remember, we're not looking at we're not neurologists. We're not trying to diagnose,
Exactly.
since seizures. We're trying to see, is there, so in sepsis, for example, you get seizures in sepsis. It's unlikely to affect one part of your brain. It's a septic syndrome, so you will get it everywhere. It's the same thing with autoregulation. It's the same thing with multiple trauma. It's unlikely that you would prevent a small embolus, but you want to see the overall oxygenation. You want to see the overall function. So to me, looking at global perfusion is what is important, because even with a PO2 probe, you're only looking at a few millimeters of oxygenation. You don't really know what's happening in the rest of the brain. But if you don't look, you won't know. And that's the beauty of it. I think we lost you, or we're still there?
Thank you. I lost the connection in between.
Okay.
So, yeah.
Okay.
So thank you, Dr. Mata. So if I may request Dr. Prashant to tell me how about integrating multi-organ dashboard? Would it improve titration of sedation and help identifying hypoxemia, hypoxia, and shock-like states earlier?
One word answer is yes. But when I say for the practice, as a clinician, I will advise that we need to put our clinical acumen, identify my subset of the patients which are at increased risk, and make protocol like triaging that this subset of patient would go 100% on multi-organ, multi-channel monitor. And then you would have a subset of patient where, okay, these patients, I can try doing without it, looking at my progress. So I'll, despite having all these newer monitors which club multi-organ monitoring, I would still say that we need to put our clinical acumen, identify the subset which definitely should be on 100% multi-organ monitoring systems. And yes, more and more of non-invasive is coming up. Still, I say that invasive ones are gold standard. So whenever in doubt, go for the invasive ones. But to start with, non-invasive ones give us a very good idea about any deterioration which can be picked up very early in these patients, and we can definitely prevent secondary brain injury to it.
Dr. Dikshit, what is your take on multi-organ dashboards and titration of sedation and identifying hypoxemia earlier?
Most important aspect, what I personally feel, that you have to ensure that one, you have to control the agitated spikes, that is one in the brain, so that it controls indirectly the intracerebral pressure. You also need to see that the central metabolic demand is also reduced, and at the same time maintain the hemodynamics of the patient. So in order to maintain that, more importantly, you need to choose your sedation very, very properly, and you must use the right, most important thing is the right drug for these kind of patients, especially when these patients are in multiple organ failure. You must have sedation goals and titration, and use validation tools for giving sedation like the RAS or the SAS, and aim for a lighter sedation unless a deep sedation is really required, especially in refractory amount of ICB. Do a daily interruption and see whether the patient wakes up, avoid over sedation, and maintain a good amount of a sedation depth. And in case if you have the facility for doing a continuous EEG monitoring, that will be really, really helpful. And you must give special considerations, especially if you have got status epilepticus in these kind of patients. Very important monitoring and sedation scores have to be really rigidly monitored. The main goal is to maintain the hemodynamics, maintain oxygenation, prevent secondary insult to the brain and other organs.
I wonder if I could add one quick thing here, if I may. I think as emergency physicians, as critical care physicians, if you look at the incidence of awareness in ED and in patients undergoing investigations, it approaches 15%. Because when a sick patient comes in, the temptation is to give them as light sedation as possible in order to maintain the blood pressure. But in fact, actually, if you think the incidence of that is 15%, if you consider the people who don't survive, the incidence is probably a lot higher. So Stefano Romagnoli and I've written to Jean-Louis Vincent to say, guys, you talk about monitoring the brain during anesthesia and during intensive care. What about ED departments? What about transfer during ambulances? So our critical care transfer service uses depth of sedation monitoring and cerebral oximetry as they move patients between hospitals, because they go, we don't know if these patients are adequately sedated or over sedated. And it's a sticker on the forehead. So why not do it? It makes sense. And funny enough, the non-anesthesiologists are more comfortable with it more than the anesthesiologist, because the anesthesiologist thinks they know better. But the emergency physician, the critical care, no, we'll do it because it gives me a parameter. And, again, we've seen the doses of propofol come down, the doses of vasopressors come down, and the patients are not as agitated as they come in. And, we've had them monitor patients during transfer where they had seizures, and they start anti-epileptic treatment during the transfer. You wouldn't be able to see that if they're paralyzed and you're moving them from one hospital to the next. So really, the non-invasiveness of the technology begs the question, why not? Why not do it? It doesn't take anything away from us. And really, we keep talking about inventing new medications and new treatments. We don't have to invent anything. If we just do the things we do now properly, we'll improve mortality by several fold. The trouble is the things we already know work, we don't do. Controlling temperature, fighting
that's so true.
infection,
Yeah.
reducing ICPs, preventing hypoxia. We don't do those things. If we did those things well, really, we don't need any other icing on the cake, because that is what matters.
So true. So true. So that brings me to the next question, which is slightly offbeat to this discussion, and I will address it to Dr. Srinivas. So in a position as you are today, where you lead the intensive care society, how do we train our next generation to interpret advanced monitoring in a way that complements sedation strategies and oxygenation goals?
Okay. So the first thing is, when intensivists assess hypoxemia and intensivists assess shock, their tool is POCUS. Your clinical assessment of shock, your clinical assessment of hypoxemia is not complete unless you have actually mentioned what are the POCUS findings. Now, that same thing should extend to cerebral resuscitation and cerebral monitoring. This becomes an essential science or a skill for every intensivist. You may not be working full time in a neurocritical care unit, but the neurological
Exactly.
aspects of general intensive care have have a direct impact on the morbidity and the ultimate outcome of non-neurocritical care patients as well. So I would look at three skills which are essential for all intensivists. One is the transcranial Doppler. Two is the interpretation of the EEG. Oxygenation and hemodynamic parameters. Dynamics have to be mated with assessment of cerebral hemodynamics for you to ensure that the oxygenation and perfusion of the brain is maintained for every patient as a tailored, personalized prescription rather than one fixed number of MAP or one fixed number of cerebral perfusion pressure or PBTIO2. So, any intensivist who wants to call himself one, I personally believe just as you should know echocardiography, you should know how to ventilate patients, you should also know how to assess cerebral hemodynamics and electrical activity of the brain.
Perfect. So, Dr. Mata, if I may bring you in again, overuse sedation or overuse monitoring, or none, or both? Dr. Mata?
looks disconnected. So
Hmm.
may I request Dr. Balara, what is your practice in your region and your hospital?
Thanks, Prashant. I'll say optimal use of both the things is important, like in ICU. As Dikshit told earlier, like wake up call is important. Like we should wake the patients every day to see how sedated they are. So my I'll say optimal use of sedatives. Maybe probably start with propofol, fentanyl, and daily wake up call is the prime goal for all the neuro patients, irrespective of if you have neuro monitoring, then the ICP is a good guide to assess the sedation, and then one can regulate the sedation after the ICP monitoring.
Dr. Mata is back, please. Dr. Mata, over to you.
Yeah, sorry about that. I just got disconnected momentarily. I'm not quite sure I understand why the ICP is a good measure of sedation. Because, I'm not sedated and my ICP is normal, I hope. So really, I mean, the ICP is a function of your brain compliance. And so really, it could rise. Persistent ICP rises just mean that your brain compliance is reduced. So it's a question of what you want to do as opposed to just looking at the ICP alone. For me, I would look at the ICP, look at the pupils, look at the oxygenation, look at everything that's associated with that, and make sure the depth of sedation is adequate for that patient. Rather than, we have a lot of patients that raise their ICP when they're almost in burst suppression. So it's not a great indicator of depth of sedation per se.
So we're talking about multimodal monitoring here, and we also are talking about one size doesn't fit all.
Absolutely,
Yeah,
absolutely.
perfect. So
I mean, we have seen since we've introduced SetLine on our unit that a lot of patients have rises in their ICP, but it's not related to sedation. They're in a flat EEG almost, and it's because the CO2's gone up, or maybe the blood pressure's dropped, or maybe they're having a seizure. But it's not to do with the sedation per se. So it's actually important to make sure that you look at the rest of the parameters before you give hypertonic saline every time the ICP goes up, or increase the sedation every time the ICP goes up, because it's not always related to that. There are multi-factors, and that's what we try and teach people. Look at the reasons why the ICP is going up and try and do the right thing. If it's metabolism, sure, reduce the metabolism. But if it's a drop in blood pressure, change the blood pressure. If it's hypercapnia, reduce the CO2. That's what we try and do.
So my last question to all of you, one innovation you wish was at every ICU bedside. So I'll start with Dr. Prashant.
A monitor which clubs non-invasive things with this EEG, NIRS, hemoglobin, and hemodynamic.
Dr. Srinivas.
I am a very hard fan of um, artificial intelligence. So I would probably would like to have a snapshot screen which actually tells me what my intracranial hemodynamics are doing, what my oxygenation is doing, what my electrical activity is doing, and therefore how to mate and combine, pick and choose the best aspects of all the guidelines pertaining to each of this. What is the tailored algorithm for this particular patient? If I can see on the screen at the bedside of my patient, that would be my best day in the ICU.
So that would really require artificial intelligence. That's yeah. What about you, Dr. Subhash?
I'll agree with Dr. Prashant. Maybe combined monitoring of the basic parameters, as well as the oxygenation, cerebral oxygenation, and perfusion is important in monitoring ICP ICU patients.
Thank you, Dr. Shalini.
For me, it would be cerebral autoregulation first, followed by ICP, EEG, some electrical activity of the brain, and then sedation. All these integrated bedside, non-invasive for sure.
Yeah, thanks, Dr. Dikshit.
Yeah, echo with what all the previous colleagues have said. One single monitor which shows all the parameters and shows that the brain perfusion is well, and the electrical activities maintaining wear.
Thank you. Dr. Mata, what would be your innovation, or what would you want?
My innovation would be, can we use what we have already
Right.
before we invent any more stuff?
Right.
Because people are not using the basic stuff in front of them. If you think 10% of people have their depth of sedation monitored, and even less have the brain oxygenation monitored, AI can help us. But, if you don't look at the basic monitors in front of you, AI can't tell you what to do. So I think if we stick to our parameters, make sure the blood pressure is all right, saturation, brain oxygenation, depth of sedation, I think we could go a long way before we need anything else invented.
Thank you. So with this, I thank you all for this wonderful discussion. And I would request Dr. Prashant for a vote of thanks, please.
Thank you, everyone. Before I put up a vote of thanks officially, there's a question from one of our members, Dr. Lenin. I'll request Dr. Basil Mata to look at this question in terms. Dr. Lenin asked you that with all these, or with the optimally available monitors, is there any better sedation or sedation combinations would you suggest for ICU? So looking at all these monitoring available and optimally doing it,
Well, I reverse that question. I think there's definitely lots of wrong ways of doing it, but I don't think there is one particular right way of doing it. So I think the right way to do it is it's less about the drug and more about brain perfusion, brain oxygenation, getting the right depth of sedation. I don't think it matters what you use as long as you use it sensibly. So that would be my view.
Thank you so much. Thank you so much. So with that, we'll come to the end of this wonderful session with listening to a great talk by Dr. Mata, his experiences, his practices, and his in-depth knowledge about the brain perfusion and monitoring. We really thank from the Society of Neurocritical Care India to Dr. Mata for joining and giving us the time. I also thank all our esteemed panelists who joined us today. Dr. Harsh Sapra, moderating the panel, Dr. Srinivas, Dr. Subhash Balara joining from Denmark, Dr. Subal Dikshit, Dr. Shalini Nair from CMC Vellore, Dr. Srinivas as President of Indian Society of Critical Care Medicine. I also thank Anupma, Gomes, and Bruno and other team for helping us conducting this. And not to forget, I thank Clarinet Shreyasi for giving us the platform and managing the platform so seamlessly. So thank you, everyone. And thank you all the participants who joined us for the day in this evening. And I hope we all had a wonderful evening. Thank you so much and have a great weekend.
Thank you all. Have a great evening.
Thank you very much. Thank you.
Thank you very much.
Thank you, sir.
Thank you.
Thank you so much, everyone, for giving us the opportunity to host the session. Good night to all of you. Thank you so much.
Thank you, Shreyasi.
Thanks.